Hello, my name's Simon Guppy, and I'm one of the DVT nurses at King's College Hospital. Just to give you some background on the presentation that I'm going to give at the moment, it's a piece of work which we did, which looked at the diagnosis of occult malignancy in patients with an unprovoked DVT. And I'm going to talk about the background to why we carried out the study and the audit. I'm going to look at the sample, the methodology, the results, and the recommendations from the piece of work that we carried out. And the work was performed really by myself and Emma G, who I think is presenting tomorrow. King's is a large hospital in London, and we have 1,500 beds spread over 3 sites. We have 2 dedicated DVT nurse-led clinics at the Denmark Hill site and the Princess Royal site. And this information that I'm giving is really looking at the incidence of occult cancer, which the information that we have available at the moment runs at about 5%, and the diagnosis of occult cancer is highest during the first year of diagnosis. We looked at a Canadian study from 2015, which had a rate of occult malignancy of about 3.9%, taken from quite a large sample of 854 people. And we wanted to have a look at whether the patients at King's were represented in the same way. So in 2016, we did an audit of 127 unprovoked VTEs, so a smaller sample, and we had a 1.6 rate of people diagnosed with a malignancy after 1 year. So we thought it'd be worthwhile repeating that, and that's what we did. So the sample that I'm going to talk about today was all unprovoked VTEs seen in our clinics in 2020 to 2021, so a 12-month period. The inclusion criteria was all proximal and distal and upper limb DVTs, and the only exclusion criteria was superficial vein thrombosis. Just to give you some background, provoked DVTs we took as women who are pregnant or on the oral contraceptive, people who already had cancer, antiphospholipid syndrome, lower leg immobilizations, COVID infection, reduced mobility, and surgery, including day surgery or hospital stays, in-hospital stays. For unprovoked DVTs, that is classed as everything else. So including long-haul travel, people who are obese or have, for example, varicose veins. Our sample is gathered via 2 places mainly. It's the emergency department and the urgent care centres in the hospitals, and also via our local GPs. And we have approximately 8 to 15 new patients every day. So to look at our methodology, Emma G and myself reviewed the DVT clinic history, our registry, and we selected all of the patients who had unprovoked DVTs. We did this between January and June in 2022, and we then went through the notes of those patients and looked to see whether within that year they were diagnosed with a malignancy. And we then presented our findings to our thrombosis committee, which is our weekly MDT with our consultants and pharmacists. So if we're going to look at the patients now, we had a total of 330. The mean age, as you can see, was 62. And the vast majority of patients, as we would expect, were over the age of 40. That was 299. We had a pretty even split between men and women with their unprovoked DVTs, leaning slightly towards men. And we had more proximal than distal DVTs. And we only had 2 people who had arm DVTs. So our current practice, which is based from our policy, which was put together in 2019, is that all patients in the DVT clinic should be seen or certainly telephoned within 1 week of diagnosis to check on their symptoms, to check for medication adherence, to see if they have any side effects or difficulty taking the tablets or the injections, and to perform a cancer screening questionnaire and some tests that you can see down here on the bottom of the screen, such as a urine analysis, chest x-ray, bone profile, PSA in men over the age of 40, and to complete our cancer screening questionnaire. The urine analysis would look, it's a dipstick, and it looks for things such as blood and protein. And our cancer screening questionnaire, which I'm going to go through later on a different slide in more detail, was put together by one of our consultants, Dr. Julia Czaprinska, and it is based on the English 2-week wait questions. So if we go on, our practice is based on 2 guidelines, which is the NICE guidance and the ISTH guidance. And they differ slightly with what to do with patients who have unprovoked DVT. The NICE guidance states that people with unprovoked DVT or pulmonary embolism who are not known to have cancer need to do medical history, baseline blood tests, including FBC, renal and liver function, clotting, but also offer a physical examination. But interestingly, it doesn't mention about doing a chest x-ray or other tests such as a bone profile, unless you think the patient, there's a clinical need for that to be done. The ISTH guidance, which is the, and I've forgotten the name of ISTH, it's a long name, International Society on Thrombosis and Hemostasis, which are a very well-known group, says that very similarly, patients who have unprovoked VT should undergo a limited cancer screening, but they're very specific that you should also have a bone profile and a chest x-ray. And really, we were looking at whether the chest x-ray and the bone profile were tests that were still needed in our group of patients because of the results that we're going to come on to shortly. So if we look at the chest x-ray, 81% of our sample size had a chest x-ray. And out of that sample size, the majority of them, 86%, were over the age of 40. And only 5 people, so just 1.9%, were seen to have something suspicious for cancer, not necessarily cancer, but something that needed further investigation. And one of the things that Emma and I thought about was, is there a cost implication, for example, for doing so many chest x-rays if they're not necessarily needed? And actually, it's not really a cost implication because they're relatively cheap. I think it's about £30 to do a chest x-ray. So this costs about £8,000 to do this. So not doing a chest x-ray doesn't save very much money. It's just really whether it's useful for the patient for a clinical diagnosis. So we come on to those 5 abnormal chest x-rays, and they were all for people who had a proximal DVT, and none of them showed any cancer. So there were things I can pick out there, such as a benign pleural plaque, a repeat x-ray was actually normal, some calcification. So no malignancy was picked up on the chest x-rays. Similarly, with the bone profile, no cancer was picked up on the 2 patients that there was some abnormality. And again, we carried that out, the bone profile, on 83% of the patients. And the 2 patients that came up with an adjusted raised calcium, one patient had no symptoms, but we notified the GP, and the other patient had experienced some weight loss, anorexia, cough, and they had a CT scan, and it showed some endometrial thickening. They went on to have a biopsy, but that was benign, I'm pleased to say. So the urine analysis is our next slide, and it was poorly performed, really. We only had 41% of urine analysis completed, and 24% of that sample was seen to be abnormal, and 8 people were seen to have a UTI. So we often found things such as blood and protein, but there wasn't anything serious that was brought up with our results from the urine analysis, although it was poorly performed. What was seen to be useful in terms of occult malignancy was the PSA. So this was performed in 82% of men. 9% had elevated results, and interestingly, 3 of those men were found to have a diagnosis of prostate cancer within a year of their DVT being diagnosed. The mean age was around 70, and there were 2 men who were in their 40s, which actually brought it down slightly, but yeah, the mean age of those men was 70. So I think it's valuable to continue with the PSA taking, certainly. Now, this brings us on to the cancer screening questionnaire, which I touched on earlier on. The cancer screening questionnaire was developed by one of our consultants, and it is a robust questionnaire which the nurse carries out after around a week. And it asks questions such as, have you had unintentional weight loss recently? Do you have difficulty with chewing or swallowing? It talks about passing urine. So do people have, men having to get up in the evening, in the night to pass urine? And if so, how often? It talks about the national screening programs, such as the bowel cancer. Are people enrolled in the bowel cancer screening program? Are women having their mammograms? So it goes into a lot of detail, and we're happy to share that cancer screening questionnaire. If you'd like to, we can email that screening questionnaire to you. So it's extremely useful. And out of those patients who had the cancer screening questionnaire, which was 89%, 30 of them, it flagged up needed further investigations and action. So 25 of those people went on to have a CT scan. 3 of them then went on to have urology referrals, and 2 of them needed to have a FIT test, which is a fecal immunochemical test. So out of those people, to break down the results of the cancer screening questionnaire in a bit more detail, 15 patients rather mentioned that they had unintentional weight loss, which was the biggest group who are reporting some sort of issue, was with the unintentional weight loss. 3 of them had an abnormal chest X-ray. 2 of them had reported bowel or abdominal symptoms. 3 had very high D-dimers. 2 had some sort of urological symptoms, and 6 were other smaller unrelated issues. So if we look then at the outcomes, patients who had a suspected cancer diagnosis within about 6 months of the DVT from this group were 11 out of that 330, so 3.3%, which was an increase on the 2016 audit, but slightly less than the Canadian sample. The mean age of the patients was 72. The gender split was 7 men went on to have a malignancy, 4 women, and the proximal and distal split was pretty much the same. It was 6 proximal DVTs and 5 distal. The next slide looks in more detail of what those patients went on to have. So unfortunately, 4 patients died within a few months, really, of having their DVT diagnosed. 1 patient had cancer of the tongue, went on to have chemotherapy and radiotherapy. 1 had prostate cancer, went on to have radiotherapy and Zoladex treatment. 1 patient had a metastatic cancer of the pancreas. You can see here, 1 patient had prostate cancer, but went on to a watch and wait treatment. So to bring that all together, we had 4 patients who did die from a malignancy within a year. 3 patients had bowel cancer, 3 patients were found to have prostate cancer, and 2 patients had a primary unknown malignancy, which were found as a result of coming to the DVT clinic. So in conclusion, to pull this all together, as mentioned, we had around a 3% rate of occult malignancy and unprovoked DVT in our patient group. The chest x-rays and the bone profile did not detect any occult malignancy. The urine analysis was inconsistently performed, so we needed to increase how well that was done. The PSA detected 3 cases of prostate cancer. The cancer screening questionnaire aided the detection of 3 occult malignancy cancers. And the physical assessment was not routinely performed, although we've taken steps to improve that. So the outcomes, the results were reviewed by our thrombosis committee, and before making any changes to practice, so we still perform chest x-rays and the bone profile, and if we are to make any changes to that established protocol, then we need to collect further data. As mentioned, we needed to improve the urine analysis practice. We're continuing, obviously, with the PSA and cancer screening questionnaire because they were very successful in highlighting malignancies. We continue to offer physical examinations at diagnosis, and we'll look at those audit outcomes. And this year we are due to review the results. Thank you very much.
Thank you so much, Simon. That was a really interesting piece of quality improvement work that you carried out. You're going to review this, obviously, going forward, but have there been any particular changes you've made in your practice or as an outcome of this, or the education that you've shared with others within your team on this?
Yeah, so we presented this piece of work as well, which is slightly sort of a side issue to the ISTH last year. We have increased the amount of people that can do the physical examinations now to ensure that it's offered to more people. We have highlighted in a different place now on the documentation to do the urine analysis, which is one thing that was, in some ways, it was just being forgotten that we weren't doing it very much. And I think in some ways, because it didn't show very much when the nurse was doing it, it was one of the things that sort of got lost. Whereas the chest x-ray, because you have to sort of go and either I can order chest x-rays, so it's easy for me to do when I'm doing the prescription, for example, and the other nurse would get the doctor to do the chest x-ray. But I think when we were doing the dipstick, sometimes because it was always normal, it was one of the things that was missed off. It wasn't in our minds, we must do the dipstick because we always find something. So we had to find a way to jog our memories so people still saw it as an important thing to do. It's the reality of that one. So that's how we changed that practice as well.
Brilliant, thank you. I know we're short of time, but so what I wanted to ask was if anybody wanted to follow up this with you, because I think, the learning from this and putting it into practice in their own setting would be so helpful. Are you happy for them to contact you or Emma if they wanted to discuss any further?
Yeah, Emma and I both mentioned that. So you can give them our emails and we'd be happy to forward it on. Probably my email more than Emma's, really, because she is inundated with stuff. So my email's fine.
Okay, thank you. What I will do for everybody in this meeting is I'll put it in the chat. And if anybody watches this on the catch up, if they want to contact us, then I can do an introductory email.
Yeah. Would it be useful for me to send you the cancer screening questionnaire so that actually if people had your email, you could just send it out to them? Would that be useful?
That would be useful. And I could also include it in the e-shot to delegates that we're sending out each day. So
yeah,
that would be great. Thank you very much.
Because there's quite a lot of, when I presented it at ISTH, there was so much, when it went onto the slide, people couldn't really see it because there's so much information. So a lot of people wanted it emailed to them so they could look at it more closely. So I'll do that after we've finished this.
Brilliant, thank you. And I'll make sure that it is made available, it is shared via the e-shots to the delegates. But again, if anybody sees this and hasn't been able to access it, either email Simon or myself, and we're happy to share.
Yeah, thanks.
Thank you very much, Simon. We appreciate your time and especially putting this in, as I know you weren't available on the actual live session. So thank you so much.
No problem.
Thank you. Bye-bye.